Anglin. Dr. Anglin obtained her MD from McMaster University in 2005 and completed her psychiatry residency training in 2010 and the clinician investigator training program in 2012, both at McMaster University. She was awarded her PhD in medical sciences, neuroscience, and behavioral sciences in 2012. She currently holds a joint appointment as an assistant professor in the departments of psychiatry and behavioral neurosciences and medicine at McMaster University. Her clinical and academic work is with the gastroenterology division at McMaster University, where she sees patients with both gastrointestinal and psychiatric disorders. And she's developing a comprehensive and integrated clinical and research program focused on gut-brain interactions. So help me welcome Dr. Anglin.
So thank you very much for that very kind introduction. It's really a delight to be here, both in person and then I guess virtually with all of you online, because this really is a passion of mine. So as you heard, I'm a psychiatrist, but my home is here in the GI division at McMaster University, where I see patients with gastrointestinal illness, a lot of IBD patients who have challenges with anxiety or depression or managing stress that's impacting their illness, but more importantly, their quality of life. So today I wanted to start broad and talk about the connections between the gut and the brain and why you've invited a psychiatrist to your Gutsy Learning series, and hopefully give you sort of the biological rationale for that. And then talk more clinically about the mental health challenges associated with IBD, and then talk a little bit about coping with anxiety and depression. Briefly touch on some future directions, but hopefully also move into more of a discussion, and I really look forward to people's comments as well as questions. I think most people, even outside of this audience, know that the gut and the brain are connected, and it's actually evident in our common language. We talk about trusting your gut reaction to something. Butterflies in your stomach before giving a talk to really the experts on IBD, which are all of you. Feeling sick to your stomach with emotion. We know that when you feel stress and strong emotions, you feel it in your gut. And that's because the gut and the brain are biologically very connected. So in science, we talk about the gut-brain axis. And our brain and our gut are connected by a big nerve that runs from the brain to the gut called the vagus nerve. And that connects our brain with what we sometimes call our second brain, which is actually all of the nerve cells in the gut. And our gut has a huge collection of nerve cells that function a bit independently, but also collect messages and send them to the brain. And then the brain also sends messages down to the gut. And in addition to this big nervous system connection between the gut and the brain, there's connections through hormones that the brain secretes that affect the gut, and that the gut secretes that affect the brain. And there's inflammatory connections. So everything that happens in the gut, if it's an inflammation response, that then travels up and is delivered as a message to the brain. And it's really bi-directional. So there's constant communication between the gut and the brain, much more so than other organs. So the brain knows what's happening throughout the body, but the gut and brain are really connected by all of these different pathways. And most of you are probably aware of this really astounding fact that there are at least 10 times more bacterial cells in our body than there are human cells. So we're actually more bacteria than we are human. There's more bacterial genes in us than human genes. So that's over 100 trillion bacteria, and I'm not a numbers person, so that's actually 250 times the number of stars in the Milky Way, and 150 times as many genes as the human genome. So this is just an astronomical amount of bacteria. So now we like to talk about the microbe gut-brain axis. And all of these little bacteria in the gut send signals to those gut nerves that then send them up to the brain. But also the brain can send messages down to the gut and change motility and secretion, which changes the resident habitat of these bacteria and can change the composition there. So we know that the brain and the gut are connected, but also all that bacteria in there is also signaling to the brain and being changed by signals coming down from the brain. So just to finish sort of this broader picture of why we talk about psychiatry in the brain in patients with IBD, I just want to talk about a couple really important animal studies that I think will give you a sense of how much this field is evolving and how much we're learning about how much the gut and the brain are connected. So I want to talk to you about a study that was actually done here by Chemek Bursic and Steve Collins, who are researchers here at McMaster University. And they found that if you took mice and you gave them antibiotics, they became more exploratory, more outgoing. And that was paralleled by some changes in neurochemicals in the brain called BDNF. But if you took mice that had no bacteria, so they were raised in our germ-free facility, so you might remember the Seinfeld boy in a bubble. These are the mice in the bubble. They have no bacteria. If you give them antibiotics, there was no change in behavior. So then they thought, let's look into this a bit more. It looks like that gut bacteria is actually affecting how the mice actually behave and act. So they took advantage of the fact that there's two kinds of mice that we study in science. One's called BALB/c, the other NIH Swiss mice. You don't need to know the names, but basically the BALB/c mice are always kind of timid and anxious. And the NIH Swiss mice are much more outgoing and gregarious. So if any researchers out there, these are just convenient pictures. These aren't actually the mice strains, but they look anxious and outgoing, so remember that. And what they did is a really neat experiment where they took those mice in a bubble, so these mice have no bacteria in their gut, and they took that timid little mouse with no bacteria, and if they gave it the gut bacteria from the outgoing mouse, it became outgoing. But if you took that normally outgoing mouse with no gut bacteria and gave it the gut bacteria of the anxious mouse, it became anxious. So you could actually change the behavior of these mice by doing these transplants of the gut bacteria. So I think this is really important in terms of how we sort of think of how important the gut is on impacting things like psychiatric symptoms. I know it's a stretch from mice, but I think we're starting to get to understand how this happens in people too. And then just very, very briefly to tell you about probiotics. So in another set of studies done here at McMaster, they used a mouse that has an infection of a particular bacteria, T. mirus, that causes chronic colonic inflammation, so sort of a model of IBD. And they show more anxiety than mice who don't have this infection. But if you give them a probiotic, that anxiety normalizes. So again, suggesting that changes in that gut bacteria and the gut activity can change how the mice behave in terms of anxiety. So that's all good and nice little mouse studies, but what happens in people? I will say there's a paucity of studies in humans. This is a really exciting field in mice, and there's a need to move into clinical studies, and that's what our group is trying to do. But there's one sort of interesting study I wanted to mention, and in this study, they gave healthy women fermented milk product with probiotic, or a non-fermented milk product, or a placebo, a sugar drink, twice a day for 4 weeks, and they measured their emotional responses. So this is a study where you have to recognize facial emotions. So the top guy there looks kind of nasty and angry, and you have to match that to someone underneath. So to me, the woman looks a little nasty and angry, so I would match those two. The other guy looks a bit scared. So it's sort of a measure of how you're able to gauge emotional responses. And they found that giving that fermented milk product with probiotic had a statistically significant difference in how people responded to an emotional attention task. So even a short course of a probiotic seemed to actually have changes in the brain when they did brain scans, and a change in your ability to process emotions. So quite a significant effect. So how does this all relate to IBD? Well, we know that patients with IBD have elevated rates of anxiety and depression. We know that most people with chronic medical illnesses have elevated rates of anxiety and depression, but this is disproportionate to what we see in other medical illnesses. So again, we know that gut and brain connection is biologically probably contributing to this. We know that people's psychological functioning is poorer during periods of active disease, and that psychiatric symptoms can be associated with poorer prognosis, worse symptom activity, and poorer quality of life. So we already heard from Dr. Marshall's talk that this is a really emerging area in IBD. It's not just about what your scope looked like or your Mayo score looked like, but how you actually feel might be strongly influenced by other factors like the effect on the brain. We know that depression is a risk factor for failing to achieve remission with a biological treatment. In this study, it was infliximab. And it's a significant predictor of disability. So in my practice, I often see patients who have seen the gastroenterologist, they've been told their scope looks great, and they come to me saying, why do I still feel just so awful all the time? And they're almost disappointed that the scope didn't show the active disease because they're having symptoms. And sometimes if we treat the depression or anxiety or help manage their stress, their symptoms get better. And that's probably because we know the brain is connected, remember, through the big vagus nerve, inflammatory responses, hormonal responses. It's not all in your head in a sense, but actually it is. The brain is an organ, and it's directing signals down to the gut that can cause symptoms in a very, very real way. We know that stressful life events also predict occurrence of a flare. So it's not that, again, it's just you can't cope with stress. It's actually a very biological mechanism by which stress can induce a flare over time. So if you're not managing stress, it can certainly worsen your disease course. So the most important thing is actually what IBD patients feel, and in a number of studies, if you ask IBD patients, they will tell you that stress is a major contributor to their development of disease and that it influences their disease activity. Patients tell me frequently that the unpredictability of their illness makes it very challenging for them, and that loss of control is a huge source of stress. Control over their bowel habits, control over what they can normally do in terms of fatigue. We heard that in our patient talk. Body image, social isolation, not able to reach their full potential as a result of disease, all sorts of other factors that contribute to the sense of loss of control in their life. So how do you start to cope with some of these factors? In a 30-minute talk, unfortunately, I can't tell you how to cope completely, but I can kind of highlight some of the key things that I focus on with patients. The first is really stress management. So at a very basic level, how do you reduce overall levels of stress? We know that stress releases a big hormone in the body called cortisol, which has all kinds of effects on all body systems, but also the gut. So we know at a very basic level, if you learn to manage stress, most diseases get better. And the ways we often teach patients to start to manage stress are through things like mindfulness, relaxation strategies, breathing strategies. I'm not going to go through all of these. There's actually some really good apps on your smartphone that you can start to learn some of these, or meet with therapists to learn online. One of the most simple ones that I thought I would just take you through is actually just how to breathe properly. And we know through actually a number of studies, not necessarily in IBD patients, but in other populations, that if you just take time to breathe a few times a day, it can actually reduce overall stress levels. So what we teach patients is called box breathing, and it's really simple. So if people want to do it, they can try, but you certainly don't have to. What you really do is learn to breathe in on a count of 4 really slowly, then hold your breath for 4 seconds, then breathe out for 4 seconds, and hold for 4 seconds. And you do that for a few minutes at a time. And if you actually do it sitting calmly, feet planted on the ground, palms up, close your eyes, you will actually start to notice that you'll feel more calm. For people with really high stress, it can take quite a while to notice a change, but even simple interventions like this can be effective when people are feeling really overwhelmed by stress. The next sort of thing we often talk about is sort of problem solving. We're all creatures of habit, and when we're experiencing something difficult, our natural reaction often is avoidance and withdrawal. So if we're developing anxiety about sort of going to restaurants with friends because there might be different food or we don't know where the bathroom is, often the reaction is to stop going out. The challenge is the effect that has on quality of life. So how do you learn to live with the symptoms and still enjoy quality of life rather than the avoidance? So we talk a lot about sort of problem-solving techniques. How do you even just identify the stressors and triggers? Sometimes people have difficulty even putting into words. It's just all overwhelming. And how do you start to break that down into what's triggering difficult emotions? How do you start to make more effective decisions? How do you look at creative ways of solving problems? Accurately identify the barriers that are preventing you from achieving your goals. And then, of course, accepting things that aren't solvable. So the illness is going to cause some changes in your life that you may not be able to change. But how do you accept that? Problem solve around the things that you can change, but accept the things you can't. Some of the other big themes that can help with coping are tolerating uncertainty. So that's a huge thing. I don't know what my disease is going to be like next week. I meant to go to Florida. What do I do? Behavioral activation. So again, how do I re-engage in things that I used to enjoy? Social support. And the main sort of technique we use to work on these things is called cognitive behavioral therapy. And it's a psychological treatment, a talk therapy, that's been the most studied probably in irritable bowel syndrome, and there's now emerging studies in inflammatory bowel disease that this is effective at treating anxiety and depression and improving symptoms and quality of life in patients with IBD. So sometimes I feel like this, the patient saying, don't hold back, I want you to feel like you can say anything that comes into my mind. And unfortunately, psychiatrists aren't mind readers, and this is not the type of therapy we usually do anymore. Cognitive behavioral therapy is actually very active and collaborative. So it's not lying on a couch with a psychiatrist sitting silently. It's both of you being active partners. There's homework, so it's a lot of work, and it's focused on the here and now. So it's not a lot about past traumas or childhood. It's a lot about what's happening right now and how do you work on that. It's time limited. It's not years and years of treatment. It's usually about 10 to 12 sessions, and it's very structured. And it's focused on developing new skills to help you cope. And it really revolves around sort of a triad that when we are feeling stressed or down or worried, there's often thoughts that are associated with that. And those thoughts then trigger sort of physical sensations and emotions that lead to a change in our behavior. So for example, a thought might be, I can't handle this, I'm going to have an accident, everyone will think I'm disgusting. You might start to feel some nausea, stomach pain, feeling hot. And the behavior might be to leave or avoid the situation, or safety behaviors, sort of making sure you only go with someone that you really know to something, always checking out where the nearest washrooms are. These things aren't all bad, but sometimes they start to interfere with quality of life if you're just not going out or not engaging in things. And sometimes when the disease is actually in remission, people still have the anxiety and continue to do these things when they actually could be re-engaging in life. So what we start to do in cognitive behavioral therapy is start to look at what are those maladaptive thinking patterns. What's a realistic thought, and what might actually be an overvalued idea or a negative automatic thought. And how do we come up with a more balanced or rational thought? So it's not just about thinking positive, it's coming up with just a much more realistic or balanced pattern of thinking. And the more you learn to do this, you can actually change the pattern of thinking. So in patients with anxiety and depression, there have been studies doing brain scans before cognitive behavioral therapy and after, and actually different parts of the brain will light up. So you've actually retrained your different patterns of thinking. And then we work on the physical sensations through things like relaxation strategies that we talked about. And then we work on the behaviors through sort of exposures to avoided situations in a way that the patient feels in control of, that they're very manageable things to start to do, but starting to push those boundaries a little bit. Heard about going on a golf course where you don't know where the bathroom is. That might be down the road, not when you first start treatment, but you know, if golf was a passion of yours, how do you start to get back to that, and what you need to have in place to feel safe to do that, but still engage in that experience. We look at the problem-solving skills and stress management. How do you sort of cope with things better? And if we target all of those things, we start to look at what are your patterns of thinking that are causing challenges. So catastrophizing is often a common one. So that's sort of going to the worst case scenario. So you start to feel your stomach upset or have a change in bowel frequency, and you think, I'm going to be back in hospital, I'm going to have another surgery, I'm not going to get out for 6 months. So that sort of worst case scenario kind of thinking. That could happen. So it's not about saying, well, that's never going to happen. But what's the more balanced thought? Okay, something's happening here. I need to, see my doctor or get some treatment, figure out what's going on, but not going to that worst case scenario right away. Overestimating probability is common in people. So, what are the chances that this is, going to result in something terrible happening? And people would tend to overestimate when they're dealing with stress or anxiety or depression. Mind reading, so starting to think everyone will think I'm disgusting, that sort of thought. You don't know that to be true, and actually chances are most people are more supportive than we think. And then we talked about some of these other sort of strategies. The other side is pharmacological treatment. So I've sort of talked about some non-pharmacological treatments, relaxation strategies, psychological therapies. In patients with moderate to severe anxiety or depression, we also talk about medication treatment, and that's usually in the form of antidepressant medications. They haven't been studied as much in patients with inflammatory bowel disease, I will say. So in a lot of other populations, in patients with stroke or cardiovascular disease, there's lots of large, what we call randomized controlled trials. There just has not been a lot of attention to treatment of patients with IBD who require antidepressant treatment. My clinical experience is that most patients do well on antidepressants, but we have to be careful in the antidepressants we select because some will have GI side effects, and we want to avoid those. Sometimes we can take advantage of that, though, because some will actually cause a bit of constipation, which can be helpful. Some promote diarrhea, which is not usually helpful in this population, but sometimes in the IBS patients can be helpful who have predominantly constipation. So sometimes we can take advantage of that, but they have to be monitored carefully. And most patients with inflammatory bowel disease will need lower doses than other patients, often tend to be more sensitive to side effects, and that has to be taken into consideration. And then what I think is actually the best form of treatment is when we combine pharmacological treatment for those who need it with non-pharmacological. So rather than just putting you on an antidepressant and saying, I wish you well, can we look at all of these other strategies to help you manage stress and anxiety that are lifelong skills that will improve quality of life over time? So just to tell you a little bit, not to blow our horn here, but I think we're very fortunate at McMaster to have sort of an integrated program. And I think John Marshall, as well as Paul Moyetti and the other gastroenterologists here, were really ahead of the times when they recruited me to develop an integrated program and recognize that mental health is a large part of the disability and impaired quality of life that patients with IBD experience. So I see patients in the 2F digestive diseases clinic here at McMaster alongside the gastroenterologist. I think that has many important functions. So it improves communication. We can chat about the case before I see the patient, after I see the patient, keep in touch. And also it reduces stigma. So for some patients, coming to see a psychiatrist is not something that they had thought they would be doing, and it can be a bit scary and stigmatizing, and if they're just coming to the same clinic they're used to coming to, that can be helpful. I sometimes tell a bit of an anecdote that not that long ago I had a patient, and we have an assistant who takes the patient to the rooms, and she came and she said, "Oh, this patient is not happy to be seeing a psychiatrist." I said, "Okay, well, I'll do my best." And I went and saw them, and then when she was showing them the way back out, they said, "What do you mean she can only see me in 2 weeks? I need to see her sooner than that." And so she said, "What did you do in that hour?" But it really was about sort of some fear around seeing a psychiatrist, but then she was really on board about what could be offered. And so I think having an integrated program is really the way to go. We've recently recruited a psychologist as well who's doing some cognitive behavioral therapy and some of these other techniques with patients. We only have a short-term funding for her, so hopefully we can continue that, because I think it really adds to what we can offer patients. And I think integrating clinic and research work is really important. So I hope I sort of whet your appetite about what the research in this area is showing in some of our animal studies, and that we need to move that now into clinical populations. So we're starting to do some of those studies. So we're actually doing a study of cognitive behavioral therapy and measuring gut bacteria before and after. So can we actually change people's gut bacteria by changing the way they're thinking in terms of anxiety and depression? So all kinds of interesting things. So I think in terms of future directions, I think we need better evidence-based treatment. So again, more research in IBD and what mental health means to patients with IBD, but also how do we treat patients in the best and most effective ways. As I said, there's a lack of actual studies in patients with IBD. We base our information on patients with other illnesses. We need improved access to specialized and integrated treatment for mental health, so we need more examples like we have here at McMaster, where there's easy access to psychiatrists who have specialty in this area and understand what patients with IBD are going through. I was talking to a colleague who runs our anxiety center at McMaster, and she said, "I'm so glad you're now doing this," because she said, "We used to get all these patients with IBD, and they had anxiety, and they'd come to our groups, and they'd talk about having accidents, and we'd say, no, you've got to park your IBD over there. We're just here to talk about your anxiety." But they'd say, "But my anxiety is about having the accident and about the IBD," and you really can't just separate them. You need to really address them together. So I think we need improved access for patients around the country to integrated psychiatry care and focus on their mental health. I think we need to take these really exciting animal studies and look at people. Can we treat anxiety and depression through manipulations of the microbiome? And what does the fact that we can change this bacteria in a mouse and change their anxiety, what does that mean in terms of how we understand patients with IBD who have anxiety and depression? And hopefully that would lead to some new interventions. Are there changes in diet or probiotics? Our fecal transplants, which some of you might be aware of, are very promising in IBD. We're looking at how fecal transplants change anxiety and depression in the patients with ulcerative colitis in our studies. So I think it's an exciting time for me in terms of what we can start to offer patients, but I think it's a time where we need to actually hear from patients about what's important to them in terms of these research priorities as we move forward. So I think we're moving into questions. This is one of my favorite GI psychiatry jokes. Hate is a pretty strong word. Are you sure you're not just lactose intolerant of your mother? And that's the cow saying it. So there are few GI psychiatry jokes. That's the only one I've come across. So maybe I'll wrap up, and I think it's time for questions.